Hi, everyone. We are ready to start now. Sorry for the slight delay. We were just getting everything ready. So, good afternoon, and thank you for joining us today for our webinar on updates in marginal zone lymphoma. I'm Kirsty, one of the lymphoma care nurses, and I'll be your host for today's session. We also have Liz here with us, who is also one of our lymphoma care nurses. I'd like to thank Dr. Masa Lasica and Dr. Jason Hu, who will kindly be presenting today. Just a little bit of housekeeping before we dive in. I've just got a few items to mention. We encourage your participation in today's session. So if you have questions, please put them into the Q&A function at the bottom of the screen, as the chat function will not be monitored, and we will have Q&A at the end of the presentations. If you miss anything or would like to rewatch the session, it is being recorded and will be uploaded to our website. This link will be sent to your email once the recording is available. If you have any technical issues during the webinar, please email nurse@lymphoma.org.au and we will try to address these for you. So I would like to introduce our presenters for this afternoon. Dr. Masa Lasica is a haematologist and clinical researcher at St. Vincent's Hospital, Melbourne, where she leads the indolent lymphoma and chronic lymphocytic leukemia program. Masa's clinical research focuses on the use of novel agents to improve outcomes in patients with indolent lymphoma, CLL, and multiple myeloma. She's an investigator on a number of national and international clinical studies and is a member of the Australasian Leukemia and Lymphoma Group and Australasian Lymphoma Alliance. Jason is a haematology advanced trainee at St. Vincent's Hospital, Melbourne, where he's involved in the management of patients in both inpatient and outpatient settings to provide holistic care in the treatment journey. He has a broad interest in all areas of haematology and has previously participated and published a quality improvement project aiming at facilitating safe and early hospital discharge after treatments to improve patients' quality of life. Over to you, Masa and Jason.
Thank you so much, Kirsty. So a change in slides?
Yes, I can see your introduction now.
Oh, wonderful. Oh, okay. Thank you. Thanks, everyone, for this really wonderful opportunity to talk about marginal zone lymphoma. I just wanted to, I guess, lay out a bit of a plan for what we would we'll try to get through, but we'll see whether at some point we need to give people a little bit of a break. So we will just talk about what marginal zone lymphoma is, what are the different types, and how do they affect the patient, and then what does indolent mean, which is another very common word that comes with the marginal zone lymphoma conversations. And then we'll go through a few cases just to sort of, I guess, ask some questions, and Jason's going to be presenting these cases to me and asking me questions, which might be the same questions people in the meeting might be asking themselves, and then I'll answer those as well as I can, and then we will go through some novel agents and new therapies, which are the exciting future of treating marginal zone. So as the first point is just to sort of step back and think about where marginal zone lymphoma fits. So this is an overview of what non-Hodgkin lymphoma is. So there's Hodgkin's lymphoma and then non-Hodgkin lymphoma. So that's pretty much everything else. And for non-Hodgkin lymphoma, we can see we have the T cells or B cells, which are both part of the immune system. So the cells that protect us from bugs. And then in this B cell group, we have the aggressive types, which are the more common one, and the indolent group. Now, these percentages do vary in different countries and different populations, but it's just a rough sort of number to give you an idea of how this all fits together. Now, I apologize that the CLL is encircled. It's not really part of the talk. I just couldn't remove it. The area of interest for us is down here at the marginal zone area. So you can see that it sits in the non-Hodgkin's lymphoma group, under the B cell umbrella, and then in the indolent group of lymphomas. So what does indolent really mean? It means that the lymphoma is slow growing. So it's not something that is growing so quickly and is so aggressive that it becomes life-threatening very quickly and needs treatment immediately. It's in fact the opposite to that. Often people might have been living with this for a very long time until it starts causing problems, and often it's actually picked up incidentally when someone's having routine blood tests, or they might be having a blood test for something totally different, and then it shows up, or they might be having a scan for one reason or another, and then there's an abnormality in their lymph nodes or other parts of the scan, and then the process starts of trying to work out why it's there. Of course, once that information is presented to someone, it can be scary and cause anxiety, and so it's important that there's an opportunity for the doctor to go through what it actually means and what needs to happen. So let's say somebody does have an incidental diagnosis of a indolent lymphoma. What we would do in that setting, after a careful assessment, if we decided that it was indolent and was not causing any problems to the body, we would then watch that lymphoma without any intervention. So there would be, a frequency of visits every 3 months or 6 months, depending on the scenario. And at that time, there's clinic appointments, some assessment physically, and blood tests often. And if everything's fine, then we don't do anything else, and we just catch up again in 3 to 6 months or so. It's important to remember that watch and wait is not a period when the patients are, meant to be sitting there waiting for this lymphoma to cause problems. We always try to reassure our patients that it is safe to, just put it aside and live life as to the fullest, rather than worrying about it all the time. Now, when we get to the point where it's starting to cause problems, that's when we would be thinking about treatment. And some of the indications for treatment are either blood counts being low because the lymphoma is affecting the bone marrow where the body makes blood cells, or the spleen, which can be big, and that can cause low blood counts because the spleen is sort of like a cleaning organ that removes blood cells, but when it's really big, it can do its job a bit too much. It can be because the lymph nodes are getting big, or the spleen is getting big, and it's just causing discomfort due to their size or compressing something. Different symptoms, and we'll go through this a little bit more later, or autoimmune conditions, so the immune system's getting confused and causing problems. So that's the sort of things we'd be looking at each time a patient comes to clinic. So now let's talk about marginal zone lymphoma specifically. So it belongs to a group of it belongs to non-Hodgkin cell lymphomas, and it's actually a group of lymphomas. It's not just one, which does make it a little bit tricky sometimes to get your head around what we're really dealing with, and then also how to treat it. But I'll do my best to take you through it. And if we were in the same room, I would encourage you to put your hand up and stop me if you need to clarify. But in this instance, maybe put your questions in the chat. So, as I said before, they come from arise from the immune cells called B cells, which normally are very important in our body to fight infections. And it seems to be a little bit more common in women, but certainly can affect men as well. This is what it looks like under the microscope. So if you take a blood sample from somebody who has lymphoma cells in their blood, this is what it's sort of on a smear, and then under the microscope, these little red dots are the red blood cells. These little tiny purple spots are the platelets, so the sticky cells, and these bigger sort of chunky cells are the white cells, so immune cells. But these ones look abnormal, and they do have the appearance of marginal zone with the little projections here. So someone looking at the microscope in the laboratory would be alerted that these cells don't quite look normal, and that would in itself trigger some further tests. This picture here is just to show you that, you know, the lymphatic system, which is where the lymph cells usually travel, includes many parts of the body. This is the spleen sitting there just on the left side under the diaphragm. This is a lymph node. So all these little orange dots are lymph nodes. You can see they're everywhere, and they're there for a good reason, to protect us from infections. And this is what, if you took one and sort of enlarged it, that's what it would look like. The bone marrow, which sits in the long bones, that makes red blood cells, and the lymphoma can spread there and cause the normal cells to be lower in numbers and not be able to do their job. And then this is in the blood, where we would be looking for red blood cells, white cells, and platelets. So let's look at the types of marginal zone lymphoma. So there are three sort of big or main groups. This one here, called extranodal mucosa-associated lymphoid tissue marginal zone lymphoma, is a very big word, and it is, you know, even for us who deal with it all the time, a mouthful. But essentially what it's saying is that there are these areas of the immune system called lymphoid tissue that are lining, that are sitting in the mucosa. So what you see in your mouth, in the lungs, different parts of the body that have areas of lymphoid tissue sitting there. And in some cases, they can become lymphoma cells, and specifically marginal zone lymphoma cells, and cause symptoms through that. That is very commonly in the stomach, so it's called gastric mold marginal zone lymphoma, and is generally, in the vast majority of cases, caused by Helicobacter pylori infection, which continues stimulating the lymph system there, and it somehow triggers this lymphoma to grow. There are also several other non-gastric, so other parts of the body that are not stomach, mold marginal zone, such as other parts of the bowel, the thyroid, the eye, the skin, lungs, salivary gland. So you know, a whole host of areas where the same thing can happen due to some form of stimulation to the immune system. This process of lymphoma can start. So that's the extranodal. Then the second group is splenic marginal zone lymphoma. And the third group, and the least common one, is where the marginal zone lymphoma only sits in the lymph nodes. So let's have a little look at each one. So what are the symptoms of mold marginal zone? If it's in the stomach, it would cause symptoms largely related to that. So stomach discomfort, indigestion, some nausea, vomiting. Some people can lose weight because of all that. And obviously, when there is something in the stomach that's not meant to be there, it can cause blood loss and therefore low iron and anemia. And then the non-gastric, I won't go into all the individual details, but really just to say that the symptoms relate to the area where the lymphoma is. So that's the mold marginal zone. Now, the symptoms of splenic marginal zone, if you think about it, it affects the spleen, the bone marrow, and the blood. So what we would get from that is enlarged spleen, and that can just simply by its size cause discomfort in the abdomen, difficulty eating normal sized meals because it's pushing on the stomach and just taking up space. It can, there's lymphoma in cells in the blood and in the bone marrow causing low blood counts. And then lastly, the nodal is largely in the lymph nodes, so they're swollen, and that in itself can either cause pressure on other structures or nerves and cause discomfort. And then lastly, the B symptoms, which you might have been asked in clinic when you see your doctor, have you had any B symptoms, which really is just a reflection of either there being a lot of lymphoma cells which are using up energy, or it can be a sign of transformation to a more aggressive lymphoma, which can occur in a small number of patients with marginal zone, and they can cause that can cause B symptoms. And they really are made of three main things. So drenching night sweats, where you have to change your clothes and your bedding, weight loss, significant weight loss without trying, and temperatures of 37.5 or 38. So that's a summary of what marginal zone lymphoma is. It has been for a long time a little bit of an orphan disease because it's not as common as some of the other lymphomas, but there is a lot more love going towards trying to make sure that we all do the same thing and standardize the way we look after patients with marginal zone lymphomas. And we did indeed recently publish a sort of like a guideline for Australian and New Zealand doctors who treat lymphoma, so that everyone is on the same page. And that certainly is hopefully an important and useful tool for the doctors as well. So, Kirsty, any questions that you think we should go through so far?
We can just do the questions at the end. Yeah.
Sounds good. Okay. Can you see the slide still?
Yes.
Yeah.
All right. So now on to over to Jason for our first case.
Thank you, Marsha. So the first case we have Mrs. RL, who's in her 50s. She was referred by her gastro specialist for opinions on management. She initially presented with some tummy pain and on the gastroscope found to have a large ulcer lining her stomach. The biopsy taken from the ulcer shows features that suggest marginal zone lymphoma, and with the staining showing positivity of the bacteria mentioned before, H. pylori. So with the information we have, how would you proceed to stage this newly diagnosed lymphoma?
Thank you. So this is sort of, I guess, an example of one of the lymphomas we discussed before. This is a gastric marginal zone, and on biopsy that was confirmed, but also very helpfully, we did identify the bug that we know can cause this, and that's really helpful because we have very good options to treat it. But just to answer Jason's question first, so staging would go to diagnosis. What does the patient have? So looking at different parts of how they're presenting. So symptoms, clinical examination, blood tests, endoscopy, scans, so getting the full picture. And then the staging bit is where is in the body is the lymphoma. So all those tests help us. It's like a puzzle, really, looking at different parts of the information and then putting it together into the full picture. We also want to know how much disease does the patient have, and that again goes back to looking at the scans, looking at the blood and how much lymphoma is in the blood, in the bone marrow, and then putting all that together to give us a good impression. And then also we would be looking at prognosis. Doesn't always apply to every lymphoma in terms of the information that we get, but it is something that we think about as well. So how will the patient do long term? So now back to you, Jason.
Yeah, thank you, Marsha. So now that we have this diagnosis of gastric marginal zone lymphoma, and we found that it's positive for the bacteria, now we probably should talk about how would you approach in terms of treatment. And once we treat it, how would you assess response, and how frequently should we follow up after we start the treatment?
Yes, thank you. So once we have detected the H. pylori, the first thing that we would do would be treating the bug with antibiotics and proton pump inhibitors. People would potentially be familiar with, the Somex and Nexiums and things like that. So the combination of those two types of drugs is very effective. And we know it's called H. pylori eradication. And we know that a vast majority of patients, 75% or so, do respond long term. So you only get treated once and then they continue without a further relapses. The responses can take quite a while. So even though the bacterium is gone, we would still on gastroscopy, so when the camera goes into the stomach, we would still be picking up lymphoma often for quite a while, sometimes for a year or two, but provided that the patient is feeling better and the lymphoma is not growing, we are comfortable watching it, provided that the Helicobacter pylori is not in the picture anymore to continue causing problems. This table is very busy, but really all it shows that if you look at these numbers here, this is the percentage of patients who have had an excellent response, and you can see that quite a few of these clinical studies reported very high responses of, high rates of complete responses, but it can take quite a while for that response to kick in. So we would just sit back and patiently wait for that to happen. So again, provided that the symptoms are getting better. Now, just back to here. So if we've treated the H. pylori and the patient's feeling better, that's great. But we would also want to know, is the H. pylori gone? If it is, then we would just watch every 3 to 6 months with a camera in the stomach, and otherwise, just step back. If the H. pylori is not gone, then we would treat with a different antibiotic, trying to get rid of it. So let's see what happened with Mrs. RL.
So she returns after 3 months after the treatment has started. Unfortunately, there's still some persistent tummy pain, but there's no other symptoms suggestive of fever, sweats, or change in her appetite. We did the camera test as proposed and had another biopsy at that time point. That shows the changes that is still suggestive of lymphoma presence, but now at this point, it was negative for the bacteria after the antibiotic treatment. As a part of the CT scan as well, there was no other new enlarged lymph node. So we're at this point, 3 months after treatment, there is still some symptoms, there's still some changes with lymphoma, but the bacteria is gone with antibiotics. So Marsha, what should we do next?
Yeah, so this is a case where even though the bug is not there anymore, the patient in front of us is not feeling better. So that's a very important part of information here, and we know that the lymphoma is still there. So we need to ask ourselves, well, we can't just let them continue being unwell. What else can we do to treat this lymphoma? Now, very fortunately, this kind of lymphoma responds very well to radiotherapy. And the key really is that, we've tried the antibiotics, that didn't work, the lymphoma is still causing problems. So we would be thinking about treating with radiotherapy. This results in complete responses in over 90% of patients, and in one of the studies, 98% of patients were still alive at 5 years. So it's very effective and quite well tolerated as well. So that would have been the next treatment for Mrs. RL, I suspect. What do you think, Jason?
Yeah, I agree. I think she went on to have radiotherapy as we planned. And fortunately, at the end of the treatment, her symptoms are much better. The camera test shows no further evidence of lymphoma. And the scan was also showing that she's in complete remission, as the study suggests that the majority of the patient is able to achieve.
Yeah, so a good outcome there. All right, now are we all ready for case 2? And no choice because I can't hear anyone, so I think we'll just go ahead. Would you like to discuss the second case, Jason?
Yeah, so this case is Mrs. CK. She's a bit elderly in her 80s. Was referred because on the routine blood test, it was noted by her doctor that she has very high white cell count in the number of 30s, whereas normally the white cell count or the total white cell count is less than 4. And on the blood film, as we showed earlier, there's some suggestion of marginal zone lymphoma. Her other red cells and platelet counts are normal. On the CT scan, there was enlargement of her spleen, and the diagnosis was made of a splenic marginal zone lymphoma. She doesn't really have much in the way of symptoms from the spleen enlargement itself. So Marsha, what is the current recommendation in the case of splenic marginal zone without any other symptoms?
Yes, so look at this is you know, a very good example of what splenic marginal zone is. So the parts of the body that are affected are the spleen and the blood. So the spleen is bigger than it should be, and the lymph cells in the blood are looking like splenic marginal zone. There were a few other tests done on these cells to confirm that we were indeed dealing with splenic marginal zone, but I left that off just so that I don't confuse people. So we did come up with the diagnosis of splenic marginal zone lymphoma, but the key question was, do we need to do anything about it now that we know what we are dealing with? And given that there were absolutely no symptoms, the blood counts were normal, we were quite comfortable to go to the approach that we do have for indolent lymphomas, and that is, if it's not causing problems, leave it alone and just watch it. So that's exactly what we did, and we indeed got away with that for over 2 years. Now, what happened after that?
So during those 2 years of close monitoring on the blood tests, as you can see, the white cells are slowly coming up, initially in the 30s and become 50s and over 100s. And associated with that is the other cell lines or the other blood counts are getting lower. And Mrs. CW now is having symptoms of some tummy discomfort, and the scan shows that her spleen is also getting bigger, which is likely the reason for her tummy discomfort. We did proceed to a bone marrow biopsy, given her numbers are getting higher and her blood cells are getting lower, and that shows in the bone marrow of the factory that produces cells, there is presence of lymphoma. So now that there are symptoms and other blood counts to suggest the lymphoma has becoming more involved, what are the treatment options we can offer here, Marsha?
Yeah, so now we're at the point where the key is symptomatic. So this lymphoma is now causing problems, and we can't keep watching it. We need to do something about it. Good news is that for splenic marginal zone lymphoma, we have very simple treatment, but it works very well. So immune therapy, the one that we get in Australia is rituximab, is a very effective type of treatment for specifically for splenic marginal zone. So rituximab, as I said, is an immunotherapy drug. So I'll just try to sort of take you through what it does and how it works. So this is a lymphoma cell. This light pink and the dark pink is the all one cell, and then on its surface you can see these little sort of signals sticking out, and they tell other parts of the body what type of cell they are. One of them is very important because it is called CD20, and it tells the cells surrounding that this is a B cell, and it's often found on the surface of a lymphoma cell, because as you might remember from earlier, lymphoma marginal zone belongs to the B cells in origin. So the CD20 is sitting there very conveniently on the lymphoma cell surface. And now the antibody that has been produced as part of this drug recognizes the CD20 and comes along, which is this little purple bit there, and locks onto it and acts as a signal to the other types of immune cells to sort of call them over and say, hey, I've found a lymphoma cell, come over and help me kill it. And that's what it does. So it is essentially an alert to the immune system and a connection between the immune system and the lymphoma cell, so that the lymphoma cell can be killed by the immune system itself. So it's very commonly used in treatment of B-cell lymphomas, but in splenic marginal zone, we can actually use it on its own without combining it with chemotherapy or other drugs, and it works exceptionally well. This graph here is going to be a little crash course into how, as clinicians, we look at how well a drug is performing in certain diseases. I want you just to focus here on the red line. So with this graph, the flatter and the higher the line is, the better the drug is working. So every time the line drops, that's patients on the trial losing response and the lymphoma coming back. But if it's like this, sitting really high up rather than dropping down all the way, you can see that it's almost at that over 90%. So at 10 years, majority of patients were still doing very well and not needing any other treatment. So with very simple and easy to tolerate therapy, we can send the lymphoma into remission and keep it there for a while. So this would be the one of the recommended treatments for splenic marginal zone that's sitting in the spleen and the bone marrow. Splenectomy, which is surgical removal of the spleen, has also been used and certainly is still. It is also effective. Different different groups of clinicians have reported different time frames for how long the lymphoma response once the spleen is out, but it's somewhere between 3 and 8 years. However, it is a surgical procedure. The spleen is removed from the body and therefore can't do its job. And so there is a significantly increased risk of infections, which is lifelong. So that's an important consideration, particularly when we have rituximab, which is the treatment here, that leaves the spleen is still left in place and can do its job after the treatment. So you might be asking yourself, well, Marsha hasn't mentioned any chemotherapy yet, and we are halfway through the talk. That's because so far we haven't needed to use it, and that is really a wonderful thing. But we do have to resort to chemotherapy sometimes, especially if, for example, this one here has spread past the stomach or the local tissue and has affected other parts of the body where simple measures just won't fix it. The splenic marginal zone as well, if it's spread to lymph nodes and other parts of the body, and also the nodal marginal zone generally needs chemotherapy as well if it is causing symptoms. So in those instances, we would be combining the immune therapy with chemotherapy. So I'm just going to, so when we combine chemotherapy with immunotherapy, we come up with the even longer word, chemoimmunotherapy, CIT. So chemotherapy, often through the drip, you would have heard, the sort of common side effects: nausea, vomiting, fatigue, increased risk of infection. With some of them, there's also hair loss, and often given through the drip. And then, as I explained before, immunotherapy, which recognizes this CD20 on the cell surface. The more commonly used one is rituximab. Obinutuzumab is, works on the same principle, but would be difficult to get in Australia. So we use rituximab in this setting. They're easy to use for treatment. They don't cause many side effects, except at the very beginning, where the body's sort of thinking, oh, is this an intruder? Why is this strange immune drug in the body? So it can cause a bit of an infusion reaction. And there's always increased risk of infections with any of these drugs, because we are using drugs that affect the immune system cells. Remember, lymphoma comes from the immune system as the sort of origin. So it's hard to not have any effects on the rest of the immune system. And again, these drugs are given through the drip. Now, Jason, I'll just hand over to you to briefly talk about potential side effects of chemotherapy.
Yeah, so as Marsha mentioned previous slides, the main thing will be lowering your immune system, make you more prone to have infection. For that reason, while you're on the treatment, we'll usually prescribe some medications to lower the chance of getting viral infection. So you're taking a tablet called valacyclovir or Valtrex. The other medication that we tend to prescribe when we are treating with chemoimmunotherapy is a tablet called Bactrim or Respirine Forte, which is prevent a opportunistic lung infection when your immune system are down for a long time. In addition to medication, we also advocate for the usual prevention vaccinations. So you'll be okay to have annual flu vaccine, twice a year COVID vaccine. You can also have Shingrix and RSV vaccine, although the RSV at the moment is currently out-of-pocket cost, and also pneumococcal vaccine as per the usual schedule. For the same reason you're immunosuppressed, we advise against any live vaccinations. The other thing that we will monitor and replace if needed is an infusion of immunoglobulin that helps you lower the chance of having a bacterial infection. The other thing is more in keeping with the long-term monitoring after we treated with chemoimmunotherapy. More of the chemotherapy side is we are mindful that this medication, while it's effective treating the lymphoma or the cancer, it can in itself sometimes cause secondary cancer down the track. Although the incidence are not very high, it is an important consideration before we start treatment, especially given the long-term outlook are so good. We'll be more focusing on the potential complication, and this will be in discussion with the patient that we're treating in the clinic.
Thank you. Okay. Hopefully people are feeling okay for the last bit of our talk, which will be what we think about and what options we have for relapsed marginal zone. And that will give us an opportunity to talk about some of the really exciting new drugs that are coming to the field as well. So what can we do when the marginal zone relapses? Jason, you happy to present the last case?
Yeah, of course. So Mrs. Jiao is in her 70s. She had 3 months history of shortness of breath, and on the lung CT scan, as you can see with the slide on the right-hand side, that shows some infiltrate on both sides. And what we see in the black area is where the air is, where the normal lung tissue is. And the slightly more patchy and white spots are the infiltrate that we're referring to on both sides of her lungs. And she had a camera test that takes some samples from the tissue with a biopsy that shows a marginal zone lymphoma. And we went through the rest of the staging process as we discussed earlier. It looks like only the lung is involved and no other lymph nodes or organ involved, and her bone marrow biopsy was also negative for lymphoma presence. So we've proceeded with the standard treatment that we discussed before with chemoimmunotherapy with a combination, and she managed to achieve a remission status. 3 years later, on regular kidney monitoring, she reported new breathing difficulty and symptoms. And on the CT scan we've done, as well as the PET scan, unfortunately, it has shows the lymphoma has recurred because it's involving now, apart from the lung where it was used to be, also involving the kidney, the lymph gland, as well as the bone. So by definition, this would be a stage 4 disease. And the lymph node biopsy again confirms the marginal zone lymphoma. So, Marsha, as we were alluding to earlier, what are some of the new or standard treatment options we have in relapse context?
Thank you. Yes. So in Australia, we don't have a huge deal. Well, we don't actually have any on Medicare, any access to new or novel agents. What we have available is using, again, rituximab with chemotherapy. That would be a potentially good option for someone who had a good and durable response to their previous treatment. Generally, you know, if they had no lymphoma for a couple of years or longer, we would think that the chemotherapy worked well, that we could try it often in a different form, different drugs, but you know, the same principle. If we were dealing with, you know, a lymphoma relapse in somebody who's quite frail or and elderly, we could try just rituximab alone, or radiotherapy in combination with the two, or splenectomy as well if we were sort of low on other options. And then in terms of the new drugs, there certainly are, sorry, there's a typo there, quite a few new treatment options, but accessible through clinical trials. And clinical trials are not always open. It depends on what is available at the time, but the doctors would always think about inquiring and looking at options for the patient. Again, you know, access to clinical trials can be tricky also for patients who are regional and far from you know, academic centres. So that's again another obstacle sometimes that we try to get around as much as we can, but it certainly isn't. It's an important factor. And then compassionate access from drug companies. Sometimes they are happy to provide the drug for free or with some sort of co-payment system, but again, it's not always available. So I will not labor the point here and go through every single one, but I just want to show you the amount of new drugs and approaches to treating lymphoma that have occurred over the last few years. So every single sort of wedge here in the circle is a different kind of approach to killing the lymphoma cell. And then you can see examples of the different drugs that are already in use through, you know, those either clinical trials or compassionate access. And I will go through just a few which are more available and sort of further down the line, but certainly it is the list is much longer than what I will cover today. So the first one I want to talk about is lenalidomide, which is being used in marginal zone and can sometimes be easier to access now because it's been around for a while. So the cost is not as high as it used to be. And the lenalidomide is an oral medication. It belongs to the group called immunomodulatory drugs, so IMiDs, often used a lot more in myeloma and other cancers, but we have used it, or we do use it in marginal zone as well. It acts by different sort of approaches. So it can stimulate the immune system to attack the lymphoma cell. It can kill the cancer cell directly. It can stop the sort of growth of blood vessels into the lymphoma so that they're not getting enough blood supply and nutrition and oxygen, and so the cells don't grow as much. And it can make the environment where the cells are growing really hostile, and so it's harder for the lymphoma cells to grow. So what is often done is a combination of lenalidomide and rituximab. You can see there recurring theme here, how rituximab is very commonly used as a combination with the other treatment option. And so in studies that have combined, we have seen over 50% of patients having a response and about a third having a complete response where the drug is where the lymphoma is completely undetectable on scans. Another important group is BTK inhibitors. This is sort of the examples or names of these drugs, but essentially there's again something that the lymphoma cells express on their surface, and there's a signal that goes down into the cell that keeps telling it to grow and grow and grow, which is too much. Normal cells don't have that sort of signal to that extent, and then eventually it turns into a cancer cell. So the drug, the BTK inhibitors, block that signal, and so the cell stops growing. Jason has prepared just a little summary on important side effects of BTK inhibitors. Jason, would you like to mention that?
Yeah, thank you, Masha. So I think it's important consideration that before we start this treatment, we assess the patient's heart and cardiovascular risk because of the potential and the very real side effect like it can happen with the treatment. So atrial fibrillation is the first one, is what we often call irregular heartbeat. It be detected on ECG or heart tracing, and that does carry a risk of increased strokes. There's also effects on your blood pressure and also heart failure. So important to assess any already known history of heart problems or blood pressure issues before we start or consider this treatment option. The other important consideration for this class of drugs is the increased risk of bleeding. So it's important to discuss with the doctors before any procedure or surgery. There was usually a period that we need to withhold this medication to minimize the chance of bleeding because of the effect it has on your body.
Thank you. So these drugs are also being combined. You've probably already guessed it, but with rituximab. And again, one of the studies that combined, or a couple of studies that looked at combination, identified that 48 to 68% of patients did have a response. So it is encouraging that we can use these drugs. And Jason, just to follow up on what happened with Mrs. DL.
So yes, she responded quite well with the combination of the BTK inhibitor with rituximab. And so you can see at the bottom from right to the left, there are less black spots on the PET scan, and she managed to achieve a complete response after the treatment is completed.
So you can see that there's no lymphoma on that scan, which is wonderful news, particularly as the combination of these drugs is very different to chemotherapy and much easier to tolerate. All right, last bit. So immunotherapy, so using the immune system to kill lymphoma cells is the new way of trying to avoid harsh treatments like chemotherapy and essentially using the body's own defense mechanisms to get rid of the lymphoma. Maybe some people in this meeting have heard of CAR T cells, which are cells that are, from the body itself. So CAR T cells or T cells are removed. These are immune system cells from the patient. They are then taken to a laboratory and changed so that they become CAR T cells. And these cells now have become changed. These cells have now been changed to be able to recognize a lymphoma cell. Then they're grown to millions and then put back into the body, and then go off looking for lymphoma cells to kill it. And this is a really interesting picture where you can see the cancer cell here, and then all these CAR T cells approaching it and trying to kill it. So it's a very clever way to use our own immune system. And another approach is, again, so if this is the tumor cell, you can see the CD20 there, and this is our immune cell, which we need, but it's sort of not quite recognizing that lymphoma is an enemy. It's just sort of ignoring it. We then put this drug in called bispecific T-cell engager, meaning bispecific, it recognizes the CD20 here on the lymphoma cell. It recognizes this signal here on our immune cell called CD3, and it's like a handcuff. It brings them together and says to this cell here, hey, here it is. And this cell then attacks the lymphoma cell and kills it. So it's just a way of alerting and connecting the immune system to the lymphoma cell. And that is the last slide. I hope you're not looking like this at the moment, but if you are, that's completely fine. And we will open the chat to questions.
Okay, thank you so much, Marsha and Jason. We now have time for our questions and answers, so I'll get straight into those. Our first question: why would my neuropathy be getting worse every week? I'm 2 years in remission, stage 4, age 65.
That's probably a bit trickier to answer than, what we have just in the chat. But I would say that, neuropathy can be for many reasons. And it is indeed one of the trickiest parts of, sorting through patient symptoms. Is it the lymphoma itself? Is it other things, or is it the treatment that was given for the lymphoma? So certainly a very important question to look into, particularly if it's getting worse despite the lymphoma being in remission.
Thank you, Marsha. And the second question: how does it affect the eyes and skin, please?
Yeah, so eyes, it can affect the surrounding structures of the eye, and so cause symptoms by pressure, by a change in vision, or causing even double vision. The skin is often a rash, which, rash is so common and can be so many different reasons. So I don't want you to go away thinking, every rash is a lymphoma. But if it's a rash that's persistent and, no clear explanation, a simple biopsy can look for a lymphoma, and that's how it's generally diagnosed.
Thank you. So next question: what is the standard time for checkups to monitor that there is no recurrence of MZL following chemo?
Yep.
After remission?
Yes. So that is, it depends a little bit on when where you're at in the follow-up. So often at the very beginning, when you've just had treatment, it's the doctors and often the patient's preference as well to keep a closer eye on things, to make sure that everything's going okay, not only for the lymphoma but also for all the complications, infections, and the other side effects of the chemo, that's all resolving. We need to remember that even though the treatment's finished, the side effects can often last much longer, and that sort of feeling of being fatigued and not quite yourself, and mentally as well, it can take a lot longer than the duration of treatment. So often at the beginning it's every 3 months, and then if everything's going well and there's no reason to continue the 3 monthly, the follow-up would be extended to 6 monthly, and if that's going well, after a while it can even be 12 monthly. Generally with indolent lymphomas, most clinicians prefer not to discharge a patient from follow-up, just because we know that at some point it will come back. But often it is guided by how the patient's feeling, how far they are from their treating team, etc.
Thank you. Next question. At diagnosis, I had a tumour near my kidney, not involving the kidney, but constricting the ureter from the outside. Although I was diagnosed with marginal zone and successfully treated with chemo, sorry, I did have bone marrow involvement. No B symptoms. What type of marginal zone lymphoma would I have had?
Again, it's tricky to know without having all the information, but you do raise a very important point. When I showed you the 3 big groups, it is a very simplistic way to think about this type of lymphoma. And I was saying to Jason, earlier today, it is one of the really, it can be a very confusing way to think about it, because there's so much overlap and so many presentations where it doesn't quite fit that picture. We present it in that way that I showed you before, because we have to have some system of, calling these different types of lymphoma something, but you're absolutely right. It can present in so many other different ways. And sometimes we just can't call it one or the other. We just call it marginal zone, and we treat it with the treatments that we would normally use for that type of lymphoma. So thank you for raising that. It is a very common dilemma that we have as well.
Thank you. Next question. Sorry. My question relates to post-treatment surveillance of marginal zone lymphoma. For example, gastric MZL lymphoma, where treatment has been successful. Initially, follow-up gastroscopies with generous biopsies are done every 6 months for, say, 3 years. The US guidelines have 5 years of surveillance, while the European guidelines refer to 3 years. Thereafter, a yearly review. What would you recommend?
Yeah, look, you've hit the nail on the head there. When we were writing our guideline here in Australia, we indeed didn't agree on a time period, because we didn't feel that having blanket rules was a suitable recommendation, and we said that it was at the clinician discretion, meaning that the doctor involved, so the gastroenterologist and the haematologist, would decide for each patient individually. But as a general rule, sort of 2 to 3 years post would be a common time period. And then after that, it would become a bit of a decision between the doctors and the patient.
Okay, thank you. The next question. I've been told that this can only be for a 2-year period, and that is maintenance rituximab. Why is this, and what would be the next step be after that? The area lymphoma for me is my head.
Look, without having the full picture there of what your lymphoma was and what the treatment plan was, maintenance is most commonly 2 years. The reason for that is the increased risk of infections if we were to continue this for a prolonged period of time, and also not really having a huge amount of evidence to say that it is of benefit to keep giving the drug. So most commonly 2 years, and that sort of, I guess, striking a bit of a balance between not exposing someone to increased risk of infections for longer than we have to, but also keeping the lymphoma under control. So it is a balance more than anything else, and also not having a strong argument that longer is going to be useful.
Thank you. Next question. I've previously been diagnosed with primary cutaneous marginal zone lymphoma and have completed radiation treatment. I'm wondering, are there any recent updates on Chih-Chiang MZL, including what causes it? Also, has anyone experienced pain or discomfort as a side effect of radiation therapy? Any experience or information would be greatly appreciated.
I'm not a radiation oncologist, so I don't want to, sort of go into too much of that long-term side effect profile question. it probably isn't my area of expertise to answer that, but I do know that it works very well. And that, you know, if it was only in the skin, that radiotherapy alone would be a very reasonable treatment option.
Thank you. Next question. I have non-Hodgkin marginal zone splenic lymphoma. Last year I had chemo and immunotherapy. It decreased the spleen size, however, was still in the bone marrow. Had a break and then had 2 rounds of immunotherapy this year, but stopped because it was making me sick. I'm now having the symptoms again, however, spleen is not enlarged. But I have been having bleeding in my left eye as well as the typical symptoms. I am having a bone marrow biopsy next week.
Mm-hmm. Okay.
I'm not quite sure of what the question is. I guess, would you agree?
Look, I wouldn't want to really comment to that, but I do want to say thank you to you for putting this comment out, because it does really show again how the marginal zone lymphoma can affect different parts of the body, but also when it comes back, it can try to play tricks on us and, you know, affect other parts of the body that initially may not have been affected. So it's a good example of how, you know, it's important to keep our mind open to where you know, it can come back to, and how to very, you know, systemically search for what it's up to in the body.
Thank you. Next question, is marginal zone lymphoma curable?
Look, it depends on where it is and at what stage. If it's spread in the body, it's not. If it is very limited, then there is an option of cure.
And we have another question that was brought up today earlier. Could my marginal zone lymphoma have transformed to Hodgkin's lymphoma? And if so, do I then have both types of lymphoma?
Is this something, is this a hypothetical, or do we know?
No, someone called us and she now has Hodgkin lymphoma, but she's wondering, does she still have marginal zone lymphoma once she's completed her
Yes,
chemo Hodgkin?
yes. Yeah, very good question. Yes, so once indolent lymphomas do have the capacity to sometimes transform into more aggressive lymphomas. The most common one is diffuse large B-cell lymphoma, but it can transform into other types as well. When that happens, we would be, the priority would be to treat the aggressive lymphoma with the treatments that we would normally use for the aggressive lymphoma. Often with that, the indolent part, so the marginal zone, is treated as well, because often the drugs are the same or similar. With Hodgkin's, it may not quite be the overlap, but the bottom line is the Hodgkin's would be the transformed lymphoma would be the priority, because that can be, by being aggressive, it can be more life-threatening. And then you would be monitored down the track for both. So for the marginal zone and the whatever the transformed lymphoma was.
Okay, thank you so much for answering that. Is there anything one should be doing while marginal zone lymphoma is in remission? How can you tell if it's recurring after you've had a splenectomy?
Look, and this goes back to, you know, I guess the worry that everyone has once they've had a cancer, full stop. But also when someone tells you, look, you have an indolent lymphoma that now needs treatment, but we can't cure it. Of course, you know, it's easy for us to say, it's in remission now, we'll just watch you, don't worry. But of course you worry that that's not easy to, you know, it's not something that you can turn off. The point of keeping our patients in long-term follow-up is so we can keep an eye on things. So, you know, symptoms that may come up, blood tests and clinical examination, and if needed, a scan. We don't do scans on patients, you know, frequently because they come with their own issues. But certainly if there wasn't a reason to do it, scans would be useful. And so we would keep an eye on those things, and we would also tell our patients, look, you know, if you started feeling tired more than usual, or if you had bleeding or lots of infections, certainly let us know earlier so we can see whether there's any problems with your blood counts or any other, you know, symptoms that might come up. So I don't know if I've answered the question, but essentially the point is the follow-up is there to search and you know, screen for certain indications that the lymphomas come back and reassure the doctor and the patient at the time.
Thank you. So next question. I'm recently diagnosed. I'm 38 years old, female. I was told about rituximab as a treatment along with bendamustine if my lymphoma grows. I'm currently watch and wait. How do I bring up the immune therapies with my haematologist? None were brought up with me in our last appointment.
Yeah, the immune therapies, are you talking about the last ones? That's would have been presumably the last bits I spoke about, the CAR T cells and the bispecifics. They are not routinely available. Sorry, they're not available in Australia on Medicare. So if there was a clinical trial that offered these drugs, the doctors would look at them and see whether, you know, they're suitable for the patient and also how they compare to what we have on Medicare. And that's generally when they're brought up. But through PBS, through Medicare, we can't access those drugs as yet for marginal zone. Hopefully in the future, yes, but chemoimmunotherapy is the standard of care for a marginal zone and that needs systemic treatment. So not just, you know, a little bit of radiotherapy or something.
Thank you. And we have another question. How does lymphoma location and the mentioned diagnostic uncertainty affect the drugs used and available?
Sorry, repeat that question. Sorry, Kristen.
How does lymphoma location and the mentioned diagnostic uncertainty affect the drugs used and available?
Yeah, look, good question. I think we go back to the, you know, sort of basic principle then. If the lymphoma is widespread and causing problems, we would be thinking that the patient needs to go on drugs that will be getting to that lymphoma. So radiotherapy, for instance, wouldn't be helpful if we needed to treat lots of areas. And so we would need to use drugs that go through the whole body. So it's either chemoimmunotherapy or one of those novel drugs that I mentioned, which sort of, you know, can treat the lymphoma wherever it is in the body. So even if we couldn't quite pinpoint which category it belongs to, if it was widespread and causing problems, we would go to those basic principles.
Thank you. Next question. My indolent marginal zone lymphoma was detected in a regular blood test about 5 years ago. I did not and still do not show any symptoms. I used to see my oncologist once a year. This has changed to no need to see him. Instead, he sees my annual blood tests and my GP checks my lymph nodes. Is this a standard approach if I'm not showing any change or symptoms?
I mean, look, I think this is a wonderful example of how watch and wait is a very reasonable way to do things when there's no symptoms, and it sounds like you've done very well. If things are very stable for a long time and really nothing's changed, as long as there is observation, be it by the haematologist or the GP, and there's a very clear plan, that sounds like a reasonable option to me.
Thank you. And a couple more questions. I've been diagnosed with extranodal marginal zone lymphoma 2 years plus. I have been referred by my oncologist for a surgeon to remove the tumour and lymph nodes on my collarbone. This is the process at present. This will be good to reduce the pain and discomfort. My fatigue interrupts my life in periods of up to 4 weeks. I'm okay with watch and wait approach and don't want to rush into radiation or chemo. what is the next treatment that may be offered to me?
I can't really comment on that. I'm sorry. You know, when we make these decisions, so many different factors come into play. But you know, just simply by mentioning that all these treatment options have been discussed means that they are being considered and potentially will at some point be part of the plan.
Thank you. And earlier we had the question about the person having the bone marrow biopsy and recurrent bleeding in her eye. So there is another question here. So my question is, should I be concerned about the recurring bleeding in my left eye?
Well, it certainly would be an indication to investigate.
Yes.
Absolutely.
Okay, I think you've answered all of the questions. Thank you. So it doesn't look like there's any more questions coming through.
That was a very interactive period. Thank you. I don't think I've
It's
ever
been really
been
great
asked by
questions.
that many questions all at once.
You really put the pressure on. Well done.
They did.
So
People did
I
very
guess
well.
that will bring us to the end of our presentation today. So thank you all for attending the webinar this afternoon. We really appreciate your time and hope that you've been able to increase your knowledge and have some questions answered on marginal zone lymphoma. Thank you once again to Dr. Masa and Dr. Jason for being with us today and sharing your expertise and knowledge. We understand this may be a lot of information to take in. If you have any questions or concerns regarding the content that has been covered today, or you're needing more information or support, please reach out to us either via email, nurse@lymphoma.org.au, or on our nurse support line, which is 1-800-953-081. We would love to see you again in our upcoming online or in-person support groups or future webinars or events. So keep an eye out on your emails and events calendar for future dates.